Rapid and reliable answers from diagnostic tests enhance treatment and infection prevention efforts. Silvia delivers fast and accurate results that help prevent the spread of infectious organisms, track resistant bacteria, and improve antibiotic utilization and stewardship. To learn more, click on the Silvia logo on this podcast page or go to silvia.pub/infection prevention.
You're listening to the 5-Second Rule, brought to you by APIC, the Association for Professionals in Infection Control and Epidemiology. Together with our nearly 16,000 members, we strive to create a safer world through the prevention of infection. Join us while we talk to infection preventionists and other experts to learn the truth about some common myths related to the risk of infection and to get tips to keep yourself and the people around you safe from infection. Hey, welcome back, everybody, to another episode of APIC's The 5-Second Rule. I'm Silvia Quevedo, your host. So, as usual, we have so much to talk about, and we are still experiencing the global COVID-19 pandemic. Today's episode is going to tackle healthcare-associated infections in the time of COVID. And if you're a regular listener, you know that we spend a lot of time educating folks on some common healthcare infections that members of APIC try to eliminate, try to stop. And there's been so much progress in minimizing the transmission of some of these infections that individuals can get when they're receiving healthcare. But during the pandemic, there have been a few setbacks. And so to help us understand why that is, we have Lisa Sturm. Lisa is the Senior Director for Infection Prevention at Ascension Healthcare based out of St. Louis, Missouri. She is currently the chair of the APIC Public Policy Committee. She has over 20 years of experience and is ideal to tackle this topic. Welcome, Lisa.
Thank you. Happy to be here.
So, Lisa, let's get into it because there have been some key publications, in 2020 and 2021, and here we are in the first quarter of 2022. And what we're seeing are some unintended consequences of COVID-19 in HAI management. There has been documented increases or uptick in CLABSI or central line associated bloodstream infections, in C. difficile infections, and in some catheter-associated urinary tract infections or CAUTIs. So set the stage for us. Where were we pre-pandemic with the numbers in terms of HAIs?
Pre-pandemic, I would say the United States was really in a good spot with HAIs. All U.S. health systems were tackling HAIs aggressively. We all had plans in place, and we had a structure. We had bundles, we had lots of initiatives, and we had a playbook. We knew how. I think it took a while to get to that point, but we knew how to manage and address the risks that I would say, pre-pandemic patient brought into the hospital or into our ambulatory settings. Of course, we know the pandemic had, different plans for us.
So up until that point, and again, our regular listeners are aware of some of this. There was a lot of work being done to address managing these unfortunate healthcare associated infections, as you said, bundles, so particular things that clinicians need to do to avoid having a patient get an infection. And then the pandemic hit. So what happened?
So, for me, from my perspective, Silvia, which is, a large health system looking across the country at how my individual hospitals were managing it, it really was, and I know it sounds very cliche, but it was really the perfect storm, because not only did the pandemic bring with it, the shortages and the staffing issues and the crisis and that emergency feeling of how do we deliver care with the surges and whatnot, but it also brought with it a patient that was critically ill in some instances with a novel virus, right? The novel coronavirus. So that was a whole new facet to how we were going to prevent infections in a whole different patient population. These patients had unique things going on in their body because of the virus. And then we were trying to figure out appropriate treatment strategies and managing them with indwelling devices, and knowing that those indwelling devices were dwelling for longer than average. So it wasn't just the circumstances of the pandemic. It was also the patients and the patient care and how we had to deliver it to manage these patients' very serious invasive infections with this virus.
So, first, there are a couple of great articles that have been published. There was a very nice commentary that was in the Infection Control and Hospital Epidemiology Journal in 2021. The authors were Tara N. Palmore and Dr. David Henderson on healthcare-associated infections during the coronavirus 2019 pandemic. And they call out, obviously, some of what you've just mentioned, in that the infection control practices were adapted to these COVID-19 wards. And some of the challenges were, as you said, patients that were coming in with a novel virus who had other illnesses or comorbidities. There were challenges in the patients themselves. But then layered on top of that, in this commentary, they explain very nicely how it was also a challenge given, staffing issues and redirection of staffing, shortages of personal protective equipment or PPE. So talk to us about, one of the things I want to get a handle on is, are the increases that we're seeing in HAIs connected to those COVID patients, or in your experience, do you know if those increases are also among non-COVID patients?
Great question, Silvia. So we actually have been studying that at Ascension, and I just was accepted for publication in AJIC. It's in press, so it's online right now, but we studied what we call at Ascension, it's kind of our own metric, hospital onset bloodstream infection. So it's all cause BSIs from 5 major pathogens, excluding contaminants. And we were able to break down that data by COVID versus non-COVID. Because initially, when we all started seeing these increases in CLABC and MRSA bacteremia and C. diff, initially the thought was that it was everybody, right? Because every patient in the hospital was more or less under the same circumstance of the environment and the staffing and the products and the PPE. But in this study in particular, when we stratified out COVID versus non-COVID, we actually found the majority of the bloodstream infections were in the COVID patients.
Okay.
So now we're doing a deeper dive on, we did change practices, right? We changed how we managed all patients, but there's something we believe more different and unique in the COVID patients, whether it's what devices we were putting in them, what location of the central line, or how long how long these devices were in the patients, how much we were culturing them, how much antibiotics, and all the other drugs they were on to manage the COVID, which I mentioned, either whether it's steroids or other drugs. So, it was kind of like almost like a perfect storm in this patient population, we believe, that set them up at a higher risk of getting HAIs. So that's where we're at. We have not done that for our other HAIs because it's a fair amount of work to look at your data and then bump it up to your COVID PCR results or your ICD-9 coding data. But that is something that we have a great interest in doing. And I encourage other infection prevention teams to do the same. And you can do that with just drilling down, on your infections and looking at if they're COVID or not.
So, that's fascinating, and that's exciting for you to sort of be in publishing this important work. So, at least in your sphere of influence, the data suggests these are the COVID-19 patients who are experiencing increased CLABSI rates, or central line associated bloodstream infection. What about, one of the things we're hearing and we've talked about on the 5-second rule is COVID-19 has also exposed in the healthcare community lapses in just the fundamentals of infection prevention and control practices. Can you speak to that a little bit?
Yeah, I use the reference, COVID, the pandemic tore the scab off of healthcare, and some of the assumptions we had made in the way of standardization and hardwiring. We're a high reliability organization. We pride ourselves on a standardized approach across the system, as most health systems are doing as well. And unfortunately, it kind of tore the scab off of standardized care because it was survival mode, right, out at the front line. So a lot of our bundles, a lot of our rounds, a lot of our routine practices, whether it's scrub the hub or hand hygiene or tubing changes or dating, supplies and equipment, kind of did fall, unfortunately, by the wayside. And getting it back, I believe, is going to happen. We are already starting to see it. Our rates rebound in a good direction. So I think we can get there. It's just now we have to think really deep about how can, if we get hit again, whether it's another surge or another pandemic, how can we even more hardwire what we have in place so that we don't lose things that we've made so many gains on in the future? That's the big $60 question right now, I think, Silvia.
Is it just $60?
$66, yeah.
I think it's $60,000. Yeah, no, that's an excellent point. Now, just to back up, because I think, this is really important, and it's stuff that our infection preventionists are well-versed on, our epidemiologists are well-versed on, our public health colleagues. But, the public, we had an episode when we first started the podcast. I think it's episode 3 or 4. I should know this, but where we interviewed some public health folks from Arlington, Virginia. And, we talked about the public doesn't hear about things until it's all gone pear-shaped or, it's all gone bad, right? Most of the time, these infections are kept at bay by the work that you all do. And the public just isn't aware, right? And so the world blows up with the pandemic, and suddenly it's all been exposed, or as you said, the scab has been torn off. But I think what the public also has to realize is that behind the scenes, there are surveillance is underway, right? So we're constantly monitoring and counting and checking on these infections so that they don't go from outbreaks or a cluster to an outbreak to an epidemic to a pandemic, right? Mm-hmm. So this is a very long-winded way of setting you up to ask, talk to us a little bit about the reporting that's gone on since the pandemic. And again, in your experience at Ascension, and certainly I know there's work at APIC with public policy and collaborating with our federal agencies and the NHSN, or the National Healthcare Safety Network. Can you just educate us a little bit on what that is again? So that's a reminder for our listeners, and then talk to us about reporting of HAIs during the pandemic.
Yeah, absolutely. So obviously, if you're a hospital that accepts CMS, Medicare Medicaid Services payments, you are going to be bound by the condition of participation reporting requirements for your HAIs, for your big 6 big ones, as we call them here. So,
and what are those? Can we go over those?
Sure. It's central line associated bloodstream infections, ICU plus required units. It's your catheter-associated urinary tract infections, ICU plus required units. It's your MRSA bacteremia lab ID, which that's an electronic lab report that sorts out community onset versus hospital onset. It's your C. difficile, likewise, lab ID that sorts out community onset versus hospital onset. And then it's 2 surgical metrics. It's the abdominal hysterectomy surgical site infection and the colon surgical site infection metric. So those are the big ones we all have to report. And some hospitals do more, but you can't really do less if you want CMS to participate in CMS. So during the pandemic, CMS did push pause on the mandatory reporting of those metrics in 2020. And most hospitals across the country jumped to take advantage of that. But at Ascension, we initially saw that happening, and we intervened and asked our hospitals to not take advantage of that. We knew that it was going to be really, really important to understand, even though the workload is extraordinary, especially when you're dealing with the pandemic, to understand the impact of the pandemic on healthcare-acquired infections. And if everybody ceased data collection, we would not be having all these great publications coming out now showing the impact. And then likewise, you can't improve what you can't measure. So it's really, really important that we continue to measure these HAIs, plus other, we've added, like I said, we added hospital onset bloodstream infection. That's above and beyond just the MRSA bacteremia. It's 5 key pathogens that we've selected as high risk at Ascension. So there's other important data points that you can use to inform your progress with infections. Now, CMS did suppress the collection of the data in your pay for performance and hack penalties for 2020. Initially, they just said it was the first 6 months of 2020, and now they've expanded to the whole year. But the clock is back on for 2021, and that's good because, like I said, we really need to better understand how we can manage HAIs in the middle of a pandemic. The workload, like I alluded to, Silvia, is extraordinary because of all the additional reporting requirements of COVID, and now with the vaccine reporting requirements. It is getting significant workload on the infection preventionists. So we that's something we talk a lot about and talk with the IPs about who else can help in the institution carry that burden because the infection preventionists are getting burned out under not just the data requirements, but all the other work that's come with a pandemic.
Got it. Yeah. And I like what you said. You can't improve what you don't measure, right?
Exactly.
And in fairness to the health systems across the country and certainly across the world, it was about managing, this explosion, this fire. And so the reporting took back seat to that. And some of the consequences we're now experiencing. I think that's an important piece because we do want to make sure that we're counting properly, that hospitals are required to report these infections through the National Healthcare or I guess it's not mandatory, but most hospitals report through the CDC, NHSN, the National Healthcare Safety Network.
Yep.
Correct?
Yep.
And, so we're talking hospitals. You're obviously at a huge healthcare system. I imagine you're also engaged with infection prevention and control for outpatient, long-term care, ambulatory.
Yes, we have all of those care entities at Ascension.
So talk to us a little bit about what you're seeing in terms of infections in those settings outside of the acute care hospital.
So I would say that most of the resources have been diverted to the acute care setting, just that's because that's where the surge hit. And then for our nursing home population, that's an even different situation because although all nursing homes are supposed to have a designated infection preventionist, we all know that the staffing for IPs and FTE allocation at the nursing home level is even less than what you have at an acute care setting. And the turnover, of those individuals can be fairly high. So they too have reporting requirements, just like the acute setting. And we do have a close partnership with our nursing homes at Ascension, which is good because we help each other. But I know a lot of nursing homes are, they might be independent or standalone facilities, so they might not have that acute care partner to lean on, and vice versa. So I think it's even tougher for those folks. And also, when you look at the CMS and the CDC requirements for nursing homes and SNFs and LTACs,
those are
skilled nursing facilities and long-term care,
acute care. Yeah, just want to make sure
it's even more aggressive, like just the testing requirements, the screening requirements, everything. It's, because it's felt that it's a more vulnerable population, everything is even more intensified. So their workload is extraordinary as well. And they have the same, they were the first to have to go with COVID healthcare personnel vaccine reporting into NHSN. And of course, they have all the other CMS reporting requirements. So it's pretty significant out there for the nursing homes.
So for sure. And we've had a couple of episodes highlighting the challenges in that setting. But, let me just go back to it. Even before the pandemic, APIC certainly for years was about, zero tolerance for these infections. One can argue, you go to the hospital, you go to the doctor, you go have surgery, you shouldn't walk out with an infection. So we're talking about even pre-pandemic, fundamentals in infection prevention and control. And where do you see us going from here, Lisa? In other words, okay, we were making great strides. Things were going great. We have this global pandemic. We could talk for 15 hours about why the pandemic even happened, because in some circles in preparedness, epidemiology, it wasn't if, but when. What are your thoughts on what do we need to do, COVID or no COVID, about managing patients in health settings such that they're not walking out with more problems than they came in with?
Yeah, that's a great question. I'm very hopeful, Silvia. We are already seeing, like I said, a rebound on our infections. We're already seeing, and it's a significant effort at Ascension for us to get, as what everybody's coining, get back to the basics. So go back, we don't have to recreate the playbook. We had it, we knew it was working. And like I said, with less COVID, we've also studied, like with our CLABSI and CAUTI and C. diff, we know our hospitals that had more COVID had higher infection rates. But we also know some of our hospitals that had high COVID were able to weather the storm, if you will. So there's a variation there, but we think with with Omicron, it brought a little bit of a less critically ill patient. It still overwhelmed the hospitals with admissions, but these patients weren't as sick as they were with Delta. So we're hoping, it didn't create that, the variable of the more severely ill patients, and likewise more HAIs. We do think that it might not pan out as bad as the Delta surge with the HAIs. But like I said, when we look at our big trends nationwide, we are seeing a rebound in our rates. So I think we're going to get there. It's just reminding people that what we had worked, but we got to get back to it. And sometimes, when you have to do something and then you get to drop it, it's hard to go back, right? Because you might have gotten used to I call it the pandemic patient care. You might have gotten used to that way, but that way might not have been the safest way for patient outcomes. It's just repeating that message, that mantra, that we have to get back to the basics.
And I think one of the messages, my personal friends are sick of me saying this, but the challenge of a pandemic is, the challenge is protecting our health systems, right? It's not to say we don't want to save lives and patients, but it is about protecting the health system. And when hospitals are overwhelmed, we're seeing the consequences. But, you mentioned earlier something about hardwiring. And so just a thought, and again, I know you're at a large health system, but, there were hospitals in crisis standards of care. Mm-hmm. And how do you go back, right? And how do you hardwire? How do we prevent that? I'm thinking of other high reliability professions and industries, the airline industry. It's like, well, I kind of want my pilot to know what to do. Right. That nuclear power plant, no matter what, better function properly. So what are your thoughts on that? How do we get our healthcare colleagues, just no matter what, I got to follow these basics? What do you think that is? Do you think it's a staffing issue? Do you think it's complex. I'm putting you on the spot, but what are your thoughts on that?
So, I'll just comment on the staffing. We hear that a lot, Silvia, right? So, and we were just reviewing blood culture contaminations today on the national committee call. And, why did blood culture contaminations go up? And, a lot of discussion around phlebotomy staffing. We lost phlebotomists, and then different people were drawing blood cultures that maybe weren't trained and competent. So there is that component when you lose staff, and then you have other staff filling in that work. And, did they have time to probably, go through the full training, sit down and watch the module? Probably not, right? It was teaching on the fly. But also, I've been thinking a lot about not just the staffing, but the dynamics and the turnover within the team, right? So much of infection prevention success is because of the team and the culture of that unit, department, or hospital. And when you've changed out the people, the bodies, you've changed the team. And we all know that, acronym about a new team, right? Storming, norming, performing. So I think that had a lot to do with it, right? Where a team is just clicking and everybody knows what to do or who to go to. There's that unit person that you go to for whether it's a hard stick or a dressing issue or whatever. And when all those people change, the names and faces change, you might lose those resources and people and those people that are always reminding each other and the influencers and stuff. So I think it had more to do with the changing of the team dynamics and because of the staffing situation, because I think most hospitals strive to keep their numbers up as best as possible, recognizing, there were still deficits, but it was the who was at the bedside was changing and shifting constantly, so I think that was a big factor. And then as far as getting back, I think, one thing, step one is to raise the awareness of what happened with the infection. So that comes in through your reports and your sharing of your data and raising the awareness with all levels within the hospital, from the person at the bedside to the person in the C-suite. So everybody has to be aware of the problem. And then really, really being intentional about what practices did we put into place that we now need to sunset because our staffing has changed, because we're not in crisis mode anymore, because we have the appropriate supplies back on the shelf. You have to be really intentional. Otherwise, things will just kind of perpetuate if nobody is really looking at, intentionally looking at it, recognizing that it might have impacted your outcomes. So that's what we're doing.
Excellent point. Excellent point. And listen, this is not to say that, health systems across the country, across the world, frankly, kudos to them for trying to just weather the storm. It's crazy. It's like,
get through the day. We hear that a lot.
Get through the hour,
just
right?
Trying to get through the day. That's what we heard a lot. Right.
Yeah. Where have you seen the role of the infection preventionist and the infection prevention community shift, both in the healthcare arena, infrastructure, and elsewhere, pre and post-pandemic? Or I should say pre-COVID currently?
Yeah, great question. So, before the pandemic, infection prevention obviously had a role in healthcare, in other congregate living settings, whether it's group homes, jails, prisons, mental health facilities. But when the pandemic came, infection prevention became everybody's business. It's always been, a public health thing, but it really, this whole, everybody kind of became an expert. We had a lot of epidemiologists and virologists popping up on social media. So I think the infection preventionist role became important in educating the public in general, whether it's social media, whether it's friends and family, but also a lot of infection preventionists were pulled into becoming expert consultants to public spaces, whether it's schools, stadiums, restaurants, and other places where the public gathers. And I know National APIC did a lot of work around publishing school guidance, which was very successful. So it did I think it elevated us. It was probably one of the silver linings of the pandemic. It did elevate the role of the infection preventionists and what we do and how we can apply our skills and talents to outside of healthcare. Probably more than anything I've ever seen in all my years in infection prevention.
Lisa, you mentioned the person at the bedside. Can you expand a little bit about what you mean and what the role of that person is?
Absolutely. So, oftentimes when we say the person at the bedside, we are referring to the clinician that's taking care of the patient. But another thing we realized during the pandemic was there's a very important person often at the bedside that because of the pandemic, we had to restrict. And that was the visitor or the family member that was coming in to visit their loved one. And there are studies that show that, visitors do contribute to better outcomes for patient safety. And whether it's, providing emotional or mental support for the patient, but also as an advocate for whether it's asking questions, learning about, how the patient's being managed, whether it's medications, side effects, but no one knows that person in the bed better than a family member or a loved one for whether it's mental status changes, pain level. And, as it relates to HAI, if you just think about a peripheral IV in a patient and, that person, that visitor at the bedside might be able to alert the nurse or the aide that, there's the site is burning or it's bleeding or the line became disconnected. There's all these little things that were taken away when, missed information, coupled with the fact that if the person was in isolation, then you're going to have less visits. Studies have shown patients in isolation get less visits by clinicians. So, I think it was important to recognize the value of the patient safety advocate at the bedside, whether that be a friend or family member, and then bringing visitors back in a safe and structured way with screening and education and PPE if warranted.
So much. Again, everybody knows I could just go on for days on this stuff, but it is so important. And, there are a lot of positives that have come out of COVID, believe it or not. And I think a more educated public, a more aware public on all things infection prevention and control are going to help. So, Lisa, we cannot thank you enough for taking the time to share your experience, your knowledge with our 5-second rule listeners. I want to just remind everybody there is so much great information, not only about how to manage infection prevention control during the COVID-19 pandemic, but really on all things infection prevention and control at www.apic.org. For our IP listeners, be on the lookout for Lisa Sturm's publication in the American Journal of Infection Control. And thank you.
Thank you so much. Hang in there, everybody.
Thanks for listening to the 5-Second Rule, produced by the Association for Professionals in Infection Control and Epidemiology staff and the APIC Communications Committee, in partnership with Human Factor. Audio tech is Blake Alphen.